Hello, everyone. Welcome to Medea's 2022 Male Infertility Preceptorship. We are excited to have you attending the second edition of our acclaimed preceptorship program launched last year. We do hope you enjoy participating in this edition as much as we enjoyed preparing this program for you. So I'm Sandra Esteves, and I'm delighted to deliver a talk dedicated to sperm DNA fragmentation and its relevance for male infertility. I want to thank you for taking the time out and being here today. So these are my disclosures. And this is the outline of the information I want to share with you today. I will start with a brief overview of male infertility and sperm DNA fragmentation. Then I will move to the clinical value of and in the indications of sperm DNA fragmentation testing. And then lastly, I will explore in more detail the clinical interventions available to reduce sperm DNA fragmentation. Well, I'm sure you have come across these facts and figures. The global estimates indicate that over 50 million men have infertility. Male factors, alone or combined with female factors, seems to contribute to at least 50% of reported infertility cases. And in developed countries, about 1 in every 8 men seek medical assistance for fertility issues. First of all, it is essential to define male infertility, which is a disease of the male reproductive system caused primarily by congenital and genital conditions, anatomic, endocrine, functional, or immunological abnormalities of the reproductive system, genital tract infections, cancer and its related treatments, and sexual disorders incompatible with intercourse. Lifestyle conditions, exposure to toxicants, and advanced paternal age are critical factors for male infertility as well. They can act either alone or by exacerbating the impact of the conditions mentioned in the previous slide. These factors are typically linked with semen abnormalities. For example, low sperm count, motility, vitality, and morphology, which a well-conducted basic semen analysis can detect. However, they are also linked with subcellular defects that harm the sperm chromatin and break the DNA, which can only be seen using specialized sperm functional testing. Over recent years, there has been a tremendous interest in studying sperm genome and epigenome. The reason is thousands of genes coordinate the sperm production, and a healthy sperm genome and epigenome are essential for the birth of healthy offspring. As you know, the sperm chromatin is packed to safeguard its integrity during sperm transport through the male and female reproductive tracts. The chromatin packing also secures the transfer of an intact paternal genome to the oocyte. However, sperm chromatin damage can occur during spermiogenesis, epididymal transit, and post-ejaculation by many non-exclusive mechanisms, including protamination failure, oxidative stress, and apoptosis. Oxidative stress is considered the leading causative factor of sperm chromatin damage. The source of oxidative stress can be anything from a specific clinical condition such as a varicocele, clinical and subclinical genital infections, advanced paternal age, inadequate lifestyle, chronic disease, and also environmental exposure to toxicants. The free radicals attack the sperm membranes as well as nuclear and mitochondrial DNA. When the free radicals attack the DNA structure, they trigger a cascade of events that may break the DNA strands. The breaks are generally referred to as sperm DNA fragmentation, which can be measured by specific laboratory assays. The association between oxidative stress and male infertility explains why sperm DNA fragmentation levels are higher among infertile men than fertile controls. Even if fertilization is achieved by sperm with DNA fragmentation, there is an increased risk that embryo development is affected, ultimately impacting reproductive outcomes, both for natural and also medically assisted conception. We have mounting evidence indicating that men with elevated sperm DNA fragmentations have reduced fecundability in terms of longer time to pregnancy and increased risk of pregnancy loss, suboptimal outcomes in intrauterine insemination, as well as IVF-ICSI cycles, and also increased risk of transferring a genetic defect that might affect the health of resulting infants. However, what is critical to understand is that the impact of sperm DNA fragmentation on reproductive success depends on the size and place of the DNA damage, and also the oocyte's ability to repair that damage. In many cases, sperm DNA fragmentation exceeds the oocyte repair capacity, or the oocyte may not be competent to repair the DNA damage. For example, oocytes of women of advanced maternal age. So it is important to think about sperm DNA fragmentation even when ART is used. The most extensive systematic review and meta-analysis examining the impact of sperm DNA fragmentation on IVF and ICSI outcomes included over 70 studies and over 10,000 cycles. This study showed a modest but significant association between sperm DNA fragmentation and pregnancy rates, regardless of whether IVF or ICSI was used as the insemination method. Additionally, in studies where patients with female infertility factors were excluded, the odds of predicting a successful pregnancy from the level of sperm DNA fragmentation were amplified, stressing the importance of sperm DNA fragmentation as a relevant paternal factor contributing to infertility and ART outcomes. Sperm DNA fragmentation may also increase the risk of miscarriage in pregnancies achieved with either conventional IVF or ICSI. In one meta-analysis including about 3,000 patients, the reported odds ratio of about 2.3 meant that if the average miscarriage rate in your clinic ranged between 10 to 15%, these rates will reach 23% in couples treated with sperm with pathological sperm DNA fragmentation levels. In practical terms, the net effect of neglecting elevated sperm DNA fragmentation for a fertility clinic performing, for example, 1,000 IVF-ICSI cycles per year with an average clinical pregnancy rate of about 40%, would be a loss of approximately 80 potential pregnancies, ultimately resulting in a live birth rate reduction of up to 15%. Well, can you afford such a loss? I can't. So I care about sperm DNA fragmentation and routinely test my patients. Sperm DNA fragmentation can be measured in the laboratory using 4 main tests: the sperm chromatin structure assay, known by its acronym SCSA, the tunnel assay, the sperm chromatin dispersion test, known by its acronym SCD, and also known as the halo test, and the COMET assay. They are broadly grouped in methods that use enzymatic reactions to label the DNA strands, like the tunnel assay, or controlled DNA denaturation to show the breaks, like the SCSA, SCD, and the COMET assay. These methods estimate the global sperm DNA fragmentation levels in a given specimen without distinguishing whether the breaks affect single or double DNA strands. Well, each sperm DNA fragmentation test uses a different method to identify the DNA break. For this reason, the sperm DNA fragmentation levels reported by one test do not necessarily line up. Despite that, there seems to be a decent correlation in the results of the 4 main tests: SCSA, tunnel, COMET, and SCD. The inter-laboratory agreement is overall high, and it has been shown that sperm DNA fragmentation measured in consecutive ejaculates has low biological variability, particularly when a fixed ejaculatory period is used. The duration of ejaculatory abstinence affects the sperm DNA fragmentation levels. The higher the abstinence, the higher the sperm DNA fragmentation levels. This recent paper by our group illustrates the importance of using standardized protocols and strict quality control for obtaining reliable sperm DNA fragmentation testing results. We assessed the intra-individual agreement of the halo test in over 200 men with infertility. We measured sperm DNA fragmentation in 2 ejaculates of same subjects within a 3-month interval using a standardized test protocol. The tests were performed and analyzed by the same observers using the same testing conditions. We used kappa statistics to evaluate the degree of agreement between the pairs of results after converting the nominal sperm DNA fragmentation values into categorical data. I mean, normal sperm DNA fragmentation rates, less than 20%, intermediate levels, 21 to 29%, and also high sperm DNA fragmentation levels, I mean, equal or greater than 30%. We also assessed the pairs of results using reliability measures for numerical values. Well, we found that the degree of agreement in classifying patients according to normal and pathological sperm DNA fragmentation classes was substantial. About 80% of patients were classified under the same class using paired ejaculates. The agreement rate was highest in ejaculates initially classified as either normal or elevated, and lowest among those ejaculates with intermediate sperm DNA fragmentation levels. The intra-class correlation coefficient was also high, and the mean difference between the pairs of observations was very low, indicating no systematic difference between paired observations. This evidence supports a single sperm chromatin dispersion test for patient classification, mainly when the first test shows normal or high sperm DNA fragmentation levels. However, a repeat analysis is suggested for intermediate level patients, mainly if an intervention to reduce sperm DNA fragmentation is considered. So besides the importance of using a validated test, assessment of sperm DNA fragmentation must be carried out in the neat semen collected after ejaculatory abstinence of between 2 and 5 days. And again, concerning ejaculation interval, it is critical to use a fixed ejaculatory abstinence length when the test is used to monitor the effects of clinical interventions to reduce sperm DNA fragmentation levels. If correctly performed, any of the 4 sperm DNA fragmentation tests provide valid information concerning the risk of infertility and the probability of reproductive success. For example, thresholds ranging from 17 to 26% can help distinguish fertile from infertile men depending on the assay utilized. Also, values above the thresholds in the range of 20 to 35% indicate a statistical probability of increased time to achieve a natural pregnancy, increased miscarriage risk after both natural and assisted conception, and increased risk of pregnancy failure by IUI, IVF, and ICSI. Yet, we need to remember that the sperm DNA fragmentation results cannot perfectly discriminate between fertile and infertile men, or couples that will have a successful IUI, IVF, or ICSI cycle from those that will not. The reason is that the predictive value of sperm DNA fragmentation for pregnancy also depends on the partner's fertility. Clinicians should understand the characteristics of sperm DNA fragmentation assays concerning sensitivity and specificity, positive and negative predictive value to interpret the results obtained. So each test has particularities and may have different clinical thresholds for specific endpoints. I feel that clinicians should use the method that best suits their needs. The decision should be considered, for instance, availability, the turnaround time for the results to be obtained, and also costs. In our clinic, we use the halo test in routine clinical practice. Our data show that over 50% of our patients have sperm DNA fragmentation values of 20% and higher, and 25% of our population have values of 30% or higher, which is considered quite elevated. Here is an example of a test report provided by our andrology laboratory. Our patients are asked to have fixed ejaculatory abstinence of 2 to 3 days before testing. The test is run using positive and negative controls, and at least 400 cells are analyzed. And each report includes information about the basic semen characteristics of that particular specimen. Our laboratory is enrolled in an external quality control program. We recently reviewed the evidence and elaborated a clinical practice guideline concerning the situations where sperm DNA fragmentation testing might be indicated. The guideline development group included reproductive urologists like myself, scientists involved in developing sperm DNA fragmentation tests, and reproductive endocrinologists. We proposed 7 main clinical scenarios in which sperm DNA fragmentation testing may be considered. They include varicocele, particularly in cases of palpable varicocele and borderline or normal routine semen analysis in which there is doubt whether the varicocele should be treated according to the recommendations of the most common urological guidelines. Cases of unexplained couple infertility or idiopathic male infertility. Third, recurrent pregnancy loss. Fourth, before intrauterine insemination. Fifth, before IVF and ICSI, particularly when a paternal factor is suspected. 6, for fertility counseling, mainly when risk factors for oxidative stress exist, and before sperm banking. In these conditions, the sperm DNA fragmentation test can provide helpful information about the contribution of sperm chromatin to infertility and possibly guide the treatment plan. Other guidelines have also included the assessment of sperm DNA fragmentation in their list of recommendations. For instance, the 2017 ASHRAE Recurrent Pregnancy Loss Guidelines provide a conditional recommendation for sperm DNA fragmentation testing during the investigation based on the association between pathological sperm DNA fragmentation levels and recurrent pregnancy loss. Indeed, the current evidence indicates that sperm DNA fragmentation levels are markedly higher in the partners of women suffering from recurrent pregnancy loss than controls. More recently, this year, the European Association of Urology Male Infertility Guidelines provided a strong recommendation for assessing sperm DNA fragmentation in couples with recurrent pregnancy loss from natural conception or failed ART cycles, and for men with unexplained infertility. And the latest male infertility AUA ASRM guideline also recommends sperm DNA fragmentation testing in couples having pregnancy losses. The main advantage of performing sperm DNA fragmentation testing in these scenarios is that it allows initiating an andrological assessment for men who would not otherwise be routinely viewed by a specialist. So then we will have the opportunity to identify and correct reversible causes associated with sperm DNA fragmentation, including lifestyle changes, accessory gland infections, and varicocele, optimizing the chances of natural conception and potentially improving ART outcomes. Interestingly, in couples with unexplained infertility, with the basic semen analysis and the physical examination and the history not showing any abnormal factor, our data show that about 17% of male partners have pathological sperm DNA fragmentation, despite, these good semen parameters on a basic semen analysis. It is also worth mentioning that after 10 years since the last manual, the much anticipated 6th edition of the WHO Semen Analysis Manual has been released with essential updates. In particularly, it incorporated new information about the clinical utility of sperm DNA fragmentation tests and provided guidelines on how each test should be conducted and interpreted. Unlike previous editions labeling sperm DNA fragmentation assessment as research tests, this new manual upgraded sperm DNA fragmentation as part of extended semen examination, and the manual acknowledged that sperm DNA fragmentation might be clinically informative in certain situations by the laboratory's choice or clinician's particular request. Let's now discuss the role of clinical interventions in reducing sperm DNA fragmentation. Well, given the association between sperm DNA fragmentation and potentially correctable conditions, medical and surgical interventions have been explored to improve sperm DNA integrity with the ultimate goal of enhancing fertility and increasing the likelihood of achieving healthy offspring. For this, obviously, we need to assess the level of sperm DNA fragmentation in our patients and perform a complete andrological evaluation. The main challenge reproductive urologists face nowadays is that the merit of proper male evaluation and treatment is overlooked because IVF and ICSI may provide the couple with a baby without the need to explain the nature of the underlying problem. However, this situation is changing, partly because reproductive medicine societies have recognized that a complete male infertility evaluation brings value, and also because the evidence supporting the benefit of clinical intervention in the male is increasing. Here is a snapshot of possible clinical interventions to reduce sperm DNA fragmentation. They include lifestyle modifications, antioxidant therapy, treatment of underlying conditions like a varicocele, genital infections, and chronic diseases, hormonal therapy, and the use of testicular sperm in preference over ejaculated sperm for ICSI. Despite information can be found in this review, more information if you want, can be found in this review article we published in Andrology, and I will highlight its main findings in the following slides. So with regards to lifestyle factors, many studies have consistently reported the adverse influence of smoking, obesity, exposure to toxicants, and an unhealthy diet on semen quality. It seems sound that lifestyle changes and avoiding exposure to toxicants may help improve sperm quality. While it can be argued that most men are educated about infertility risk factors and already follow basic recommendations for a healthy lifestyle, this recent large questionnaire-based study involving over 1,000 subfertile men from the UK provided evidence against this assumption. Interestingly, the authors showed that subfertile men frequently have lifestyle risks, and on top of that, are poorly educated on lifestyle factors and their association with semen quality. Unfortunately, the literature is poor in studies exploring lifestyle changes to improve sperm DNA quality. In one study, men consuming the product diet, which is consisted of high intake of fruits, vegetables, whole grains, nuts, fish, and low-fat dairy products, were shown to have lower sperm DNA fragmentation levels compared with counterparts taking the typical Western diet based on high intakes of processed food, red meat, high-fat dairy, refined grains, high-energy drinks, and sweets. In another small non-controlled study, a nutritional-led individualized dietary program coupled with exercise for at least 3 months reduced sperm DNA fragmentation in men from couples with unexplained infertility, which translated into better pregnancy outcomes. And similarly, a prospective controlled study conducted in India indicated that sperm DNA fragmentation rates might be decreased by adopting a lifestyle with stress control and using meditation and yoga. Well, along these lines, a pilot prospective single-arm interventional study was conducted by the group of Peter Humainde at the Skive Fertility Clinic, which I participated, with the primary goal of exploring the impact of a 3-month lifestyle intervention, primarily based on dietary changes and daily exercise, combined with oral antioxidant therapy using multivitamins, coenzyme Q10, omega-3, and oligo-elements. The studied population consisted of couples with history of failed IVF-ICSI, whose male partners had a sperm DNA fragmentation rate of 15% or greater using the SCSA. A significant decrease in mean sperm DNA fragmentation from 26% to 18% was seen after the intervention. And despite our study lacked a control group for comparison, a group of 10 healthy volunteers provided semen specimens 2 weeks apart to assess sperm DNA fragmentation and other semen parameters. So this was like our control group in this study. The mean absolute DFI decrease was 7.2% in patients after the intervention and only 0.42% in volunteers. These findings, although preliminary, suggest a potential role for lifestyle intervention and could be pivotal for designing and also assessing power calculation of future trials. Oral antioxidants have been studied for obvious reasons. Oxidative stress is considered a critical contributing factor in the pathogenesis of male infertility and is associated with sperm DNA fragmentation. Still, despite much research in this area, the evidence remains conflicting. In the latest Cochrane meta-analysis, which included 90 randomized control trials using many antioxidant regimens, the conclusion was that oral antioxidants positively impacted the chance of live birth of couples undergoing ART. However, when we carefully examined the studies looking specifically into sperm DNA fragmentation, then the evidence becomes less convincing, with no statistical difference observed in sperm DNA fragmentation rates after antioxidant therapy. Also, in the recent MOXIE trial conducted in the US, which randomized over 170 patients to receive either daily antioxidants or a placebo for 3 to 6 months, the authors did not find a difference in sperm DNA fragmentation rates or cumulative live birth rates between groups. At present, I feel that no clear recommendations can be given regarding antioxidants used as a monotherapy to reduce sperm DNA fragmentation. Treatment of male genital tract infection has been another target for intervention. The reason relates to the increased inflammatory response caused by bacterial infections in the genital tract. The activated leukocytes generate large amounts of reactive oxygen species, ultimately affecting sperm chromatin integrity. Antibiotic treatment using quinolones, tetracyclines, or macrolides reduce seminal leukocytes and reactive oxygen species levels and lowers the frequency of sperm with fragmented DNA. These agents have a negligible adverse effect on the sperm. But although the evidence is limited, some data suggests that antibiotic therapy might increase the likelihood of pregnancy in infertile men with genital infections by reducing inflammation and sperm DNA fragmentation rates. In one of the few existing studies, a reduction in sperm DNA fragmentation levels was the main difference between pregnant and non-pregnant couples. Another clinical intervention being explored to reduce sperm DNA fragmentations is FSH therapy with gonadotropins. It has been hypothesized that FSH therapy reduces germ cell apoptosis, giving the pro-survival effect of FSH on germ cells. Treatment is done with exogenous FSH administration, for example, recombinant or urinary FSH, given subcutaneously in a dose ranging from 75 to 150 international units twice or 3 times a week for approximately 12 weeks. In studies where urinary or recombinant FSH was given for 3 months to men with idiopathic infertility, a significant reduction was overall noted in sperm DNA fragmentation rates. In one of these studies, the effect of FSH therapy was more pronounced in men who carried polymorphisms affecting the FSH receptor. Although promising, we need more data about the effect of this intervention, particularly looking into pregnancy outcomes. Well, the best available evidence of an intervention to reduce sperm DNA fragmentation concerns varicocele repair. Oxidative stress has a central role in the pathophysiology of varicocele-related infertility. Patients with clinically detected varicocele often have elevated oxidative stress markers and pathological sperm DNA fragmentation levels. Varicocelectomy to men with clinically detected varicoceles, grade 1, 2, or 3, has been advocated to improve sperm quality and pregnancy outcomes. This recent paper summarized the current evidence concerning the effect of varicocelectomy on sperm DNA fragmentation. Based on 19 studies and over 1,000 patients, we found that varicocelectomy decreased sperm DNA fragmentation rates as early as 3 months after the intervention. The weighted mean difference in sperm DNA fragmentation rates was about 7%, resulting in a 30% relative reduction after the intervention from baseline levels. We also conducted meta-regression analysis that showed that sperm DNA fragmentation decreased after varicocelectomy as a function of preoperative sperm DNA fragmentation levels. The higher the baseline sperm DNA fragmentation rate, the higher the reduction postoperatively. The treatment effect was more pronounced in men with baseline sperm DNA fragmentation levels above 20%. This same study showed that sperm DNA fragmentation reduction after varicocele repair was consistent when the most common sperm DNA fragmentation assays and microsurgical varicocelectomy were utilized. The microsurgical technique is the approach I use to fix varicocele at Underford. It eliminates the varicose veins, and also we can preserve the testicular artery and the lymphatic vessels. To help identify any spare testicular arteries, I use an intraoperative Doppler ultrasound. It is a relatively simple operation carried out as an outpatient basis. Among the 19 trials in our meta-analysis on varicocelectomy and sperm DNA fragmentation, only 3 reported pregnancy outcomes after varicocele repair to reduce sperm DNA fragmentation. They all unequivocally showed that couples who conceived naturally or with ART had lower postoperative sperm DNA fragmentation rates than those who did not. This data, although limited, suggests that a reduction in sperm DNA fragmentation translates into better pregnancy rates. The last intervention I want to discuss with you today is using testicular sperm in preference over ejaculated sperm for ICSI. The hypothesis is that among couples undergoing ART whose male partners have pathological sperm DNA fragmentation levels in the ejaculated sperm, the use of testicular sperm for ICSI might overcome the oxidative-induced sperm DNA fragmentation that occurs during sperm transit through the male reproductive tract. Clinical data from 6 comparative observational trials suggest that pregnancy rates increase when testicular sperm over ejaculated sperm are used for ICSI. These studies included only men with confirmed high sperm DNA fragmentation levels on the neat semen. In studies explicitly comparing sperm DNA fragmentation rates in testicular versus ejaculated specimens of same men, sperm DNA fragmentation was overwhelmingly lower in samples taken from the testes. Meta-analysis shows that the mean difference in sperm DNA fragmentation rates between testicular and ejaculated sperm is about 25%, thus highly favoring testicular sperm. Interestingly, a study conducted at Cornell University in the United States concerning a topographical assessment of sperm DNA fragmentation across the male genital tract showed that sperm DNA fragmentation decreases progressively and significantly from the ejaculate to the vas deferens, epididymis, and testicle. The lower levels were noted in the testicles. In this study, surgically retrieved sperm from the testes also resulted in improved implantation, clinical pregnancy, and delivery rates. The same meta-analysis I showed you before showed that using testicular sperm in preference over the ejaculated sperm for ICSI improved clinical and live birth rates, and also reduced miscarriage rates. These results are based on observational studies and concern only men with confirmed elevated sperm DNA fragmentation on the neat semen. Our group conducted 1 study included in that meta-analysis. It was a prospective cohort study that compared ICSI with testicular versus ejaculated sperm in over 170 couples whose male partners had idiopathic oligozoospermia and elevated sperm DNA fragmentation, 30% or greater by the halo test. We found that ICSI with testicular sperm decreased the likelihood of miscarriage and increased the chance of live birth. In our study, 5 was the number needed to treat by testicular sperm ICSI versus ICSI with ejaculated sperm to obtain 1 additional delivery. Although sperm retrieval in this scenario means more invasive treatments for the males, it may translate into fewer treatments for the women, who generally carry the heaviest treatment burden. In this study, we also compared sperm DNA fragmentation rates between testicular and ejaculated specimen of the same men using the halo test. This subgroup analysis included 81 patients, and we found that sperm DNA fragmentation was significantly lower in testicular than in ejaculated sperm. The mean difference was 32%, representing about 80% relative reduction in sperm DNA fragmentation between ejaculate and testes. The sperm chromatin susceptibility to oxidative stress, particularly during epididymis transit, likely explains the lower testicular positivity for sperm DNA fragmentation. This is the decision tree that I use at Androfert for couples undergoing ART. After confirming that the patient has pathological sperm DNA fragmentation levels, a complete andrological evaluation is undertaken, if not already done. And we do that to identify any potentially correctable underlying factors, which will then be treated. I feel that just as all infertile women are treated by doctors with specialized gynecological training and expertise, all infertile men should also be evaluated and treated by specialists in male reproduction. In cases where no underlying factor is identified or pathological sperm DNA fragmentation levels persist after treatment, for example, a varicocele repair, we offer our patients sperm retrieval and ICSI with testicular sperm over ejaculated sperm, particularly couples experience IVF ICSI failures for no apparent reasons. In conclusion, friends and colleagues, although we need more evidence in this area, the grounds for the value of clinical interventions to reduce sperm DNA fragmentations are increasing steadily. On this basis, I feel clinicians should discuss with their patients the potential benefit of targeting these conditions associated with oxidative stress and sperm DNA fragmentation. The best evidence concerns clinical varicocele, in which surgical repair decreases sperm DNA fragmentation, positively impacting pregnancy outcomes. We have limited evidence concerning treatment of genital infections with antibiotics, FSH therapy for men with idiopathic infertility, and lifestyle interventions for healthier living that has been shown to potentially improve sperm DNA quality. However, the effects on pregnancy outcomes, in particularly live birth, also need to be further studied. Concerning antioxidants, some evidence suggests that antioxidants might alleviate sperm DNA fragmentation, but no conclusive recommendation can be given at present for specific agents, dose or duration, or effects on live birth. And lastly, among infertile couples undergoing ART whose male partners have pathological sperm DNA fragmentation levels in the neat semen, testicular sperm retrieval seems to be a valid strategy to harvest sperm with better DNA quality for ICSI, which may translate into higher pregnancy outcomes. This advice implies that a specialist has evaluated the male partner and all possible corrective measures done to improve the overall reproductive health and the sperm chromatin integrity. Just some final remarks. Male infertility has been increasingly recognized as a medical and public health concern. Its prevention and management are integral components of a comprehensive sexual and reproductive health services. All infertile couples should have the male partner screened for underlying medical and infertility conditions. A well-conducted male infertility evaluation represents an opportunity to identify relevant medical and infertility conditions many of which may be treated or alleviated. The andrological assessment may also help to guide the optimal application of assisted reproductive technology. The final goals are to positively impact the overall patient health, the couple's pregnancy prospects, and the offspring well-being. That brings us to the end. Thank you very much for being with me. Take care, goodbye, and stay with us because we have much more to offer in the second edition of Medea Male Infertility Preceptorship.